हाँ वो चेक कर रहा बस बोलना था
एक सेकंड या हेलो
बनाया था ठीक है
अपने मैचेस को
हाँ स्टार्ट कर दिया ठीक Yeah, Hanji. So, good evening, all of you. I'm Dr. Dinesh, and we are going to discuss important MCQs in general pharmacology. My advice to all the second year student, because we are starting with this first topic, general pharmacology. Whenever you come for the class, means this YouTube live as well as the app live, always remember your target should be to revise this topic first. Like this month we are having general pharmacology, then after a few weeks we will have the ANS. So revise these topics from the recorded version. So in the recording, second MBBS recording, we have the complete revision, this complete recording of all the topics of general pharmacology. ANS means all the pharmacology have been recorded. You have to read these topics and then you have to attempt these MCQs, and you will get a lot of benefit. Okay, so just confirm once कि भैया audio video everything is fine. Yeah. So let's start with this first MCQ. Which of the following is considered the brand name? So which is the considered the brand name? See this: propranolol, Indral, adrenergic beta blocker, or sympatholytic. Out of these, which is considered as the brand name? So brand means what? Proprietary name. Brand means proprietary name. So we have one proprietary name, and the another we have is the generic or non-proprietary name. So the name which we discuss in our pharmac books, these are basically propranolol, means these are generic or non-proprietary name. These are generic or non-proprietary name. But the pharma companies, they have the brand, they register their brand and they give the brand name, or you can say the proprietary name. So they have the proprietorship for that. So this Indral is the brand name of propranolol. Adrenergic beta blocker, sympatholytic, these are not name of the drug. These are, sympatholytic is a group. All the drugs which inhibit the sympathetic activity, they comes under sympatholytic. The drugs which block the beta receptor, they are beta blocker. So by this you can say sir, Indral is a brand name. So whatever the name we will discuss in pharmacology, they are the generic name or non-proprietary name, but pharma companies give the brand name. So like Crocin, Dolo, these are the brand name, but paracetamol is a generic name. Okay, so brand name given by the manufacturers. Now comes to second question. What is true regarding essential drug? What is true regarding essential drug? By name only you can see essential drug. The options are: should be present at primary healthcare center, satisfying the priority healthcare need of the population, used as life-saving or difficult to obtain. What do you say? What is the answer? You can send your answer in the comment. So what is your answer? What is essential drug? Present at the primary healthcare center, satisfying the priority healthcare need of the population, used as life-saving or difficult to obtain. So when we talk about the essential drugs are basically the drugs those meet the healthcare need of majority of population, and that should be available all times in sufficient quantities. And as per WHO, we have the essential drug list, but in India this list is called as National List of Essential Medicine. The latest list is 2022, which includes the 384 medicine. कितना medicine? 384 medicine. Yes, बच्चे. So now you can see this is the essential drug, the drugs which are satisfying the priority healthcare need of the population is the correct answer. They should be present at the primary healthcare center? No, they should be present. Some drugs for PHC, some drugs for secondary healthcare, other drugs for tertiary. Everywhere we have a separate drug. Used as life-saving? No, they are not always life-saving. Difficult? No, they are easy to obtain, easily available. So these are cost-effective, easily available. Total 384 medicines are there in this list. 384. So this is National List of Essential Medicine. Next question. What is orphan drug? What is orphan drug? What is true regarding the orphan drug? Orphan, by name only you can see orphan drugs. So orphan drugs are, by name you can understand, orphan means what? बेसहारा, कोई सहारा नहीं है तो हमें सहारा देना पड़ेगा. So drugs used in orphans, rarely used drugs for common disease, rarely used drugs or drugs used for rare disease. What is the correct answer बच्चे? A, B, C and D. कमेंट करके बताओ, कमेंट करके बताओ, so that मुझे समझ में आए कि भैया आप लोगों को कितना आता है, आपने पढ़ा है टॉपिक नहीं पढ़ा है. तो orphan drug, what is true? So in the orphan drug you can see these drugs are used for rare disease. These drugs are used for rare disease, a small percentage of population. They are not easily available. They are not easily available, difficult to obtain. Mostly they are very costly. अब सोचो बच्चे, फार्मा कंपनीज के पास तो प्रॉफिट का फायदा ही नहीं है. नो प्रॉफिट मेकिंग. तो प्रॉफिट नहीं होगा, सो दे आर नॉट इंटरेस्टेड. वो ये दवाई बनाने में इंटरेस्टेड नहीं है. तो गवर्नमेंट इज गिविंग सम काइंड ऑफ इंसेंटिव्स और टैक्स बेनिफिट टू दीज फार्मा कंपनीज. बट इंडिया में ये कानून नहीं है, तो इंडिया में ऑर्फन ड्रग्स आर वेरी डिफिकल्ट, मिलेंगी ही नहीं, बाहर से इंपोर्ट करना पड़ता है. दे आर वेरी कॉस्टली. तो गवर्नमेंट कहती है कि भैया एक कमेटी बनाओ, उसमें जो मेंबर्स होंगे दे विल हेल्प दीज पेशेंट्स. एनजीओज वगैरह की हेल्प से पैसा डोनेट करके तब लोगों की हेल्प करती है गवर्नमेंट. डायरेक्टली कोई हेल्प नहीं है. तो दीज आर कॉस्टली मेडिसिन. जैसे SMA1 होता है ना, SMA1 स्पाइन मसल एट्रोफी टाइप 1, उसका एक इंजेक्शन जो एंजाइम आता है, उसका एक इंजेक्शन का कॉस्ट 16 करोड़. अब सोचिए 16 CR कितना मुश्किल होगा. तो इसलिए ये कमेटी जो है ये हेल्प करती हैं एनजीओज वगैरह की हेल्प से, और पेशेंट्स की कोशिश करती हैं दवाइयाँ दिलवाने की. बट वी डोंट हैव द ऑर्फन लॉ इन इंडिया. US में है ऑर्फन ड्रग एक्ट, वहाँ पे फार्मा कंपनीज आर बाउंड. सो नेक्स्ट इज द फॉलोइंग आर गिवन intradermally except. So important from the route of administration. So some definition, then some route. The following are given intradermally except test dose of a drug, insulin, BCG vaccine और Montox. तो टेस्ट डोज कैसे देते हैं? टेस्ट डोज इंट्राडर्मली. इंसुलिन नॉट इंट्राडर्मली. BCG वैक्सीन इंट्राडर्मल. Montox टेस्ट इंट्राडर्मल. So this insulin is not subcutaneous, not intradermal, that is subcutaneous. याद रखना है कुछ इंपॉर्टेंट चीजें इन द रूट एज वेल. जब भी इंट्राडर्मल लगाएंगे ब्लैब बनेगा, थोड़ा एलिवेशन होगा इन द एपिडर्मिस. सो एक्सेप्ट पूछा, एक्सेप्ट इज इंसुलिन. सो इन इंट्राडर्मल बट सबक्यूटेनियसली वी यूज द इंसुलिन. तो इंट्राडर्मल, वेरी गुड बच्चे. So Montox test is intradermal, allergy test is intradermal, and confuse नहीं होना. Transdermal is different, intradermal is different. दोनों अलग अलग चीज है. transdermal, intradermal. Both are different. Okay. चलिए next question. What determine the degree of movement of a drug between body compartments? Degree of movement of a drug between body compartments. So it is a drug transport. So ionization of a drug, pH of this compartment, size of the molecule, which factor will determine the degree of movement between the two different compartments. So you know, when one drug from one compartment going to another compartment, like from the intestine to plasma, from plasma to tissues, these are the various compartments in the body. So lipid solubility, water solubility, ionization. Then drugs are acidic or basic, and the tissues are having different pH, acidic pH or basic pH. The molecular size, pharmaceutical properties. There are so many factors which are affecting this distribution, in process, transport. So all these are important. So if I ask you, sir, acidic drugs, they have more transport in the acidic area or they have less transport in the acidic area? सोचिए, ड्रग एसिडिक है और कंपार्टमेंट एसिडिक है, they will have more chances of transport, diffusion or less chances. What do you think? So all these are important factors. But when you put the acidic drug in acidic medium, it becomes non-polar, and only the non-polar drug can transport. याद रखना इस चीज का. Basic drug in basic medium, they are non-polar. तो जितना same maintain करने की कोशिश करोगे, it will becomes non-polar, because the drugs are in two state, polar and non-polar. अब कितना कौन सी state में है, that is important. So in every drug we have a pK value, and you know what is pK value? pK value is the pH of the compartment when the drug is 50% ionized and 50% unionized. That pH of the compartment when the drug is 50% ionized and 50% unionized, that is called as pK value of a drug. तो उसी से पता चलता है कितना आयोनाइज्ड रहेगा, नहीं रहेगा. pH चेंज होगा तो आयोनाइजेशन चेंज होगा. Okay guys, next question. Pick out the right statement. True पहचानना है. Microsomal enzyme always results in inactivation of a compound. Microsomal oxidation always results in decrease of compound toxicity. Microsomal oxidation results in an increase in ionization and water solubility of a drug. And microsomal oxidation results in increase of lipid solubility of a drug, so that its excretion from the organism will be facilitated. क्या सही लग रहा है आपको? What is the correct answer in this question? बच्चे सोच के बताओ. What is the correct answer in this question? What is the correct answer? Yeah. Pick out the right statement. Microsomal oxidation always results in inactivation. Microsomal oxidation always results in decrease of compound toxicity. So see one by one. Microsomal oxidation. So basically it is the metabolic process. In metabolic process we have the two, phase 1, phase 2, right? We have the two process, phase 1, phase 2. In phase 1 we have the catabolic reactions. In phase 1 we have the catabolic reaction. In phase 2 we have the conjugation reactions. So first catabolic, then conjugation. What is this oxidation? What is this oxidation? Oxidation is phase 1 reaction. Oxidation is phase 1 reaction. What happens in metabolism? Drugs which are active, they becomes inactive. That is the first possibility. Sometimes the drugs are active, the metabolites are active. That is the second possibility. The third possibility is the drugs which are inactive, they can becomes active. So all these possibilities are there. Now you can see always results in inactivation. No, that is not true. Sometimes you will see they are pro drugs, they are inactive drug and they becomes active. always results in decrease of compound toxicity. No, that is also not true. Sometimes you will see the inactive drug converts to active and the risk of toxicity will increase. It's not always there will be inactivation. But yes, one thing is for sure, that they increase in ionization or polarization. So after metabolism, the drug becomes polar, or you can say the water soluble. So this is definitely the right statement. Always remember the purpose of metabolic process. You will see the drug becomes more polar after metabolic process. More polar. The fourth option is saying that microsomal oxidation results in increase in lipid solubility. No, that is not possible. That is opposite. So the option C is absolutely correct. Option C is absolutely correct. So this increase in the drug's water solubility, which facilitate the elimination of the drug, through the urine. Okay, let's see the next question. Very simple question. Loading dose of a drug can be calculated by loading dose. So these formulas in general pharmacology, in pharmacokinetic, are very important. First is volume of distribution multiplied by target plasma concentration. This is the formula for loading dose. Clearance multiplied by target plasma concentration. This is for maintenance dose. Rate of elimination divided by plasma concentration. This is clearance. And this is the formula for half-life. So all these are the formulas. So this is about the loading dose. The loading dose depends on volume of distribution and target plasma concentration. So loading dose is the first dose which we use. First dose. So when we use this first dose, it depends on how much the drug is going to distribute in the tissues and what is the target level, because the drug not only remains in the plasma, the drug is going to distribute. So it will be out of the plasma. So you can see loading dose is depending on volume of distribution, target plasma concentration, and obviously it also depends on fraction, that is bioavailability, fraction of drug reaching to systemic circulation. So that is a bioavailability parameter. If F is not given, that means we have to assume the drug is given via IV route, because in IV route the bioavailability of the drug is 100%. So then the fraction will be 1. Let's see the next question. Very important for general pharmacology again. Very important question. Kinetics of elimination. So in the elimination after 4 half-life, in first order kinetic is 93%, 84%, 75% or 100%. How much the drug will get eliminated after 4 half-life if the drug follows first order? Just imagine the drug is initially 100. You have given the 100. After 1 half-life, from 100 to 50, 50 eliminate, 50 remains in the plasma. So elimination part is 50 after 1 half-life. After second half-life, 25 in the plasma, because 50% of 50, but 75 eliminate. After 3 half-life, 12.5. So this is almost 87.5. And in the fourth half-life, it will be 6.25 and it will be 93.75. So you can see the elimination part after 4 half-life. So after 4 half-life, the elimination part is 93.75 and the part which is remaining in the plasma is 6.25. So what is the correct answer? So you can see after 4 half-life, almost 93% of the drug is going to eliminate. So practically you can assume after 4 to 5 half-life, more than 95% of the drug is eliminated, or simply you can say almost the drug is eliminated from the body, almost. So that is 95, more than 95%, but exactly in this you can see it is 93.75. So this is the way you need to calculate. If I ask you how much time the drug will take for elimination from the body, so if elimination means almost 100%, so at least take 5 half-life, because in 5 half-life it is more than 50% is going to eliminate. Okay, so let's see the next MCQ on your screen. True regarding bioavailability of orally administered drug are all except. बहुत बढ़िया. Razvi has given the correct answer for all the questions. Very good. It means she is studying well. पढ़ते रहो. So true regarding bioavailability of orally administered drug are all except. First pass metabolism occurs in gut. First pass metabolism occurs in liver. Enterohepatic circulation leads to reabsorption of some drugs. High bioavailability means always and always high absorption of a drug. Try to give the correct answer of this question. And this is, very tricky question, but very important question. Very tricky MCQ. इसका आंसर दोगे तो मानूंगा. If you have studied well, your concepts are very strong. So what is true regarding bioavailability of orally administered drugs are all except orally administered. बताओ बच्चों, what is the correct answer? Bioavailability. Bioavailability depends on two factors. Bioavailability means fraction of the drug reaching to systemic circulation in the unchanged form. So bioavailability depends on absorption and first pass metabolism. So first pass metabolism occurs in gut. Is this true or false? That is true. In gut we have the enzymes. Many drugs, they are not having good bioavailability because they are metabolized in the gut. We have the peptidase enzyme. The peptides are metabolized. First pass metabolism in the liver. That is main. That is main. That is also true. Enterohepatic recirculation leads to reabsorption of some drugs. Yes. See what happens. The drugs are, some drugs after conjugation, they comes in the bile, and through the bile they comes to intestine. Drug given like estrogen. Estrogen after conjugation comes in the bile and then in the gut. In the gut we have the bacteria which contains deconjugate. So after deconjugation, estrogen is again free and it is reabsorbed. So this is enterohepatic recycling. So that help in the reabsorption of some drugs. So that is also true. The best example I told you, the estrogen. High bioavailability means always and always high absorption. Is this true? No. High bioavailability means either high absorption or less first pass metabolism. If there will be no first pass metabolism, then also the bioavailability will be high. It's not always high absorption. Right? Sometimes the absorption is good, but because of high first pass metabolism, it will have the low bioavailability. The best example is nitrates. Nitroglycerin is having very good absorption, but its first pass metabolism, so bioavailability will be less. Like in the nitrates. The answer, correct answer will be D. So very important. So when we say high bioavailability, that means absorption is good as well as the first pass metabolism will be less. Then only you can get the best bioavailability of a drug. So bioavailability mainly depends on two factors, absorption and distribution. This first pass metabolism. Okay. Chali. Now let's discuss the 10th question. If a drug is having 60% absorption and hepatic extraction ratio of 0.4, what is the bioavailability of this drug? You know the bioavailability depends on two factors. This bioavailability depends on two factors. This is fraction. It depends on two factors, absorption and first pass metabolism. So the absorption fraction is suppose small f and 1 minus ER. That is the formula. It depends on two factors. The small f is absorption, fraction of absorption, and this ER is extraction ratio, means first pass metabolism. That's why I told you 1 minus ER means inversely proportional to extraction. More extraction, less bioavailability. You can see the F is equal to 60 and multiplied by 1 minus ER, that is 0.4. So 60 multiplied by 0.6. So you get the answer. What is the correct answer? The bioavailability of this drug is 36%. Right? So from 100, 60% absorbed. So out of 100, now 60% in the plasma. But out of this 60, liver will extract 0.4. That means out of 60, 0.4 means 40% extracted. So the remaining 60% will reach to plasma. So 60, then out of 60, 60% is reaching to plasma, 40% extracted. So 60, 60%, 36. Right? In both way, by direct formula, using the formula, or you can simply mathematics. So the correct answer will be this one, 36%. Okay, so we have discussed the route of administration, we have discussed some definition, we have discussed some important pharmacokinetic formulas, bioavailability. Then let's discuss next topic regarding the plasma protein binding of a drug. What is true except? So regarding the plasma protein binding of a drug, all are true except. Let's see one by one. Displacement of a drug from plasma protein binding site makes more free drug available for glomerular filtration. So when we use the drug in the plasma, the drug is having two forms. One is bound form, one is free form. So plasma protein binding means bound and the remaining drug will be free. Like albumin, alpha-1 acidic glycoprotein, these are the important proteins. So displacement of a drug from the plasma protein make more free drug available. Yes, when you displace a drug from the binding sites, it becomes free and the free drug can reach to tissue. The free drug can be filtered in the plasma from the glomerulus. So that is a true statement. Second, displacement of a potent drug that is normally more than 95% bound may cause toxicity. The drug is potent, but usually it is 95% bound, so only 5% is free. But if displacement occur, the more free form increase and definitely it will cause the toxicity. Because the drug is potent, so the effect will be more. More effect means toxic. Albumin is the major protein involved in protein binding of a drug. Albumin is the major protein involved. Yes, it is the main protein. Many drugs, all the acidic drugs and many other drugs, they binds to albumin. Then drugs that are highly bound to plasma proteins have a great volume of distribution as compared to the drugs that are highly bound to tissue protein. No. In the plasma, if the drug bind to these proteins, the distribution will be less because distribution occurs only and only in the free drug. So more bound to plasma protein, that means they have less distribution. VD means distribution. So they have less distribution. So this is false. So these 1, 2 and 3 is true, but D is false. No, Patel sir. So you can see drugs that are highly bound to plasma proteins, they have the great VD. No, they have the less volume of distribution. So if you see these options, you can easily say option D is false. So the answer will be option D. right? So volume of distribution only for free drug, only for free drug. Next question, weakly acidic drugs. Weakly acidic drugs like aspirin, the best example is like aspirin, barbiturates. These are weakly acidic drugs. So these drugs bound primarily to alpha-1 acidic glycoprotein? No, that is false. They are primarily binding to albumin, not alpha-1 acidic glycoprotein. Basic drugs are binding to acidic glycoprotein, like amphetamine. Acidic drugs are excreted faster in alkaline urine. That is true. If the urine will be alkaline, this acidic drug becomes more polar. This acidic drug becomes more polar, and the polar drugs are easily excreted. Acidic drugs are highly ionized in the gastric juice. No, that is false. Acidic drugs are less ionized in the gastric juice, because gastric juice is same pH. In same pH, acidic drug in acidic pH, more non-polar, or you can say unionized. They do not cross the blood-brain barrier. It's not like that. To cross the blood-brain barrier, acidic or basic is not important. The important is unionized or ionized. It's not like in all acidic drugs do not cross the blood-brain barrier. No, that is false. So it is the option B. All are excreted faster in the alkaline urine. That's why in aspirin poisoning, in barbiturate poisoning, we do the alkalinization of urine. We do the alkalinization of urine. That is the treatment for aspirin poisoning, soda bicarbonate. Okay, let's see the next question. Which of the following drug metabolizing reaction is entirely non-microsomal? So we have the two type of enzyme, microsomal enzyme, non-microsomal enzyme. Microsomal enzymes present on microsome, smooth endoplasmic reticulum. Phase 1 reactions, which are catabolic reactions, they are mostly microsomal reaction. So phase 1 catabolic, mostly microsomal. Phase 2 is conjugation, and conjugation reactions are mostly non-microsomal except one. So in phase 2, all non-microsomal except one, and that is glucuronidation. So this glucuronide conjugation, that is microsomal enzyme reaction. Out of all phase 2, only glucuronidation is microsomal. Now oxidation, that is a phase 1, that is microsomal. Reduction, hydrolysis, these are phase 1. Phase 1 is microsomal. Remember, phase 1 is microsomal, phase 2 is non-microsomal, but out of phase 2, glucuronidation is microsomal. Now acetylation, which is the phase 2, and phase 2 is non-microsomal reaction except glucuronidation. So very simple question, acetylation. And you know total 4 important drugs which are metabolized by acetylation. These are SHIP drugs, SHIP, sulfonamides, hydralazine, isoniazid and procainamide. SHIP, sulfonamides, hydralazine, isoniazid and procainamide, SHIP. They cause SLE. Okay, next question. If a drug is eliminated by first order kinetic, if the drug eliminated by first order kinetic, because most of the drug eliminated by first order kinetic. Let's see. A constant amount of drug will be eliminated per unit of time. The constant amount, no, constant fraction of the drug. We have discussed 100 to 50, 50 to 25, every time 50%. The fraction is same, not the amount. 100 to 50, the amount is 50. 50 to 25, the amount is 25 only, but fraction is same. Fraction is same, like this. So the first option false. Its clearance value will remain constant. Yes, clearance, I told you the formula, rate of elimination divided by plasma concentration. And you can see in first order, rate of elimination is directly proportional to plasma concentration, because rate of elimination is amount. So amount per unit of time, that is rate of elimination. It depends on plasma concentration. So you can see in this 50 in 1 hour. In this you can see 25 in 1 hour. So when the concentration is high, the rate of elimination is high. When the concentration is low, the rate of elimination is low. So clearance is rate of elimination divided by plasma concentration. So it always remains same. So that is constant. In first order, that is constant. The half-life increase with the dose. No, half-life will be constant because half-life depend on clearance. So clearance constant, half-life will be constant. It will be completely eliminate from the body into half-life. No, I told you it take infinite time for complete elimination. Infinite. But more than 95% it take around 5 half-life. So the option B is true. So don't forget first order and zero order. All the lectures second year recorded, they include all these topics. Workbook based, very simply we have explained. So let's see the question number 15. With regard to drug receptor binding, what is true? With regard to drug receptor binding, what is true? A competitive antagonist has no intrinsic activity. Antagonist has no intrinsic activity. Is this true? Competitive antagonist has no intrinsic activity. So antagonist, they bind to receptor. They have the good affinity. They have the good affinity and they are having no intrinsic activity. So that is true. That is true. So you can give your answer in the comment. I can see your comments. Okay. Now, second, a partial agonist has less receptor affinity than a full agonist. Is this true? Partial agonists are not having less affinity. Partial agonists are having less intrinsic activity. The intrinsic activity will be less, not the affinity. Affinity will be same. Affinity will decide the potency, not intrinsic activity. So intrinsic activity for action. So that is not same. Partial agonist means partial, less than +1. KD is the maximum intrinsic efficacy. No. KD is not the maximum intrinsic efficacy. KD is the constant, dissociation constant. So basically KD or Km is the efficacy for 50% efficacy. The dose requirement for 50%, not for maximum. The dose required for 50% efficacy is Km or KD. So it is not for maximum, it is for 50%. And by this you can compare the potency. So 50% efficacy, the dose requirement, you can compare for potency. So all is not true. It is the option A which is true. A competitive antagonist has no intrinsic activity. That is true. It is blocker. Because intrinsic activity no means zero. Zero intrinsic activity, they are called as blockers. They are called as blocker. So they simply bound to this receptor without any intrinsic activity. Next question. All of the following statement about efficacy and potency are true except. So efficacy and potency. So let's see the definition. Very important topic again. Efficacy is usually more important clinical consideration than potency. Yes, always remember clinically we check the efficacy. Potency is not the primary criteria. You can compare the potency, but for selection of a drug, efficacy. Always remember STEP, S-T-E-P. For selection of a drug, S-T-E-P. S for suitability, T for tolerability, E for efficacy, and P for price. So suitability, tolerability, efficacy, and price. STEP, STEP. Efficacy is the maximum effect of a drug. Yes, the maximum effect of a drug irrespective of the dose. Potency is a comparative measure refer to the different doses of two drugs that are needed to produce the same effect. Yes, I told you for 50% of effect, 50%, not full, for 50% effect. So the effect is same. To produce the same effect, 50% means same effect. And then you can compare the dose. If the dose requirement is less, the drug is more potent. If the dose requirement is more, the drug is less potent. ED50 is a measure of drug efficacy. No, that is a measure for drug potency. वही तो पढ़ रहे हैं. EC is concentration, D is dose. It is the same thing, dose or concentration. So EC or ED50 is a measure for drug potency, not for drug efficacy. Not for drug efficacy, that is for potency. ED50 means median effective dose, when the 50% population is having the effect. Out of the study population, 50%. So that is median. So that you can use for comparison in potency. More dose, less potent. Less dose, more potent. Okay. We discussed some pharmacokinetic, pharmacodynamic. Then idiosyncratic reaction. Idiosyncratic reaction of a drug is. It is one of the type of adverse reaction. Idiosyncratic. So what is true regarding idiosyncratic reaction? आंसर दे सकते हैं आप कमेंट में. Yes. So it's a type of hypersensitivity reaction, a type of drug antagonism, unpredictable, inherent, qualitatively abnormal reaction of a drug, and quantitatively exaggerated response. We have usually two type of reaction. We have many types, but usually two, A and B. But we have the C, D, E, F also. A is augmented, B is bizarre. Augmented depends on drug, and bizarre is not depending on the drug dose. Augmented depends on drug dose. Dose related toxicity or dose related effect is A, augmented, but not related to dose. That is B, bizarre. So you can see quantitatively exaggerated response, that is toxicity, that is A, augmented, but it is qualitatively abnormal. So that is type B, bizarre. It is unpredictable also, not related to dose. It is not quantity dependent, it is quality dependent. So some people, inherent means gene related. Some people who are having the different gene, they get the different response of a drug. And this is called as idiosyncrasy of a drug. This is called as idiosyncrasy. It is not a type of drug antagonist or allergy. It is gene related abnormal response of a drug, not depending on the dose. It's a type bizarre reaction. Option C, idiosyncratic reaction. So unpredictable, inherent means gene related, and qualitatively abnormal reaction of a drug is called as idiosyncratic reaction. The best example, in some patients you will see chloramphenicol causing aplastic anemia. Not in all, in some patient it can cause aplastic anemia. Chaliye. Next question, therapeutic index is the ratio used to evaluate the safety and usefulness of a drug. For indication, the ratio used to evaluate the effectiveness of a drug, used to evaluate the bioavailability of the drug, used to evaluate the elimination of a drug. What is therapeutic index? It is the ratio. Therapeutic index is the ratio of median effective dose and median lethal dose. So median lethal dose divided by median effective dose. This is therapeutic index. So the ratio. So this ratio will decide the safety index. This ratio will define the safety index. If the ratio is therapeutic index ratio is more than 2, the drug is broad therapeutic index safe. Less than 2, the drug is narrow therapeutic index less safe. So this ratio is giving the safety and usefulness of a drug. Because if the narrow range, then therapeutic this usefulness will be less because safety will be less. It is not for effectiveness, it is not for bioavailability, not for elimination. This is for safety, safety and safety. Like some drugs, lithium, phenytoin, they have the narrow therapeutic index because they have the less than 2 therapeutic index. It is for safety. In this range, the drug will be safer. Median lethal dose to median effective dose. So we have a range. It is for safety. Okay. Let's see the next question. From the clinical trial drug approval process, maximum tolerable dose of a drug, new drug, will be evaluated in which phase of clinical trial? Preclinical, phase 1, phase 2 or phase 4? Maximum tolerable dose. Remember, in preclinical we do the animal study, not for human studies. That is preclinical, not for human. If nothing is written, that means new drug they are saying, that means we are talking about the humans. In human studies, preclinical is not for humans. In phase 1, you will come to know about the safety and tolerability of a drug. Safety and tolerability. In phase 2, you will come to know mainly about the efficacy, but also safety, but efficacy is main. Phase 4 is post-marketing phase. Post-marketing, after marketing, approval. So it is the safety and tolerability. Tolerability, you will get the maximum tolerable dose. In phase 2, you will get the dose range, in which range the drug can be useful. But phase 1 is safety and tolerability. And always remember, phase 3 is best data. Overall best data is phase 3. In phase 3, you will get the best data. In phase 3, you will get the best data. Always remember that. Okay? Let's see the next question. Regarding phocomelia, all are true except. Very important, historically important question. Phocomelia. नहीं मेडिको जी phase 3 is for best efficacy and safety. Best data वहाँ मिलेंगे. तो phocomelia, all are true except. Teratogenic effect of a drug, true. It's a teratogenicity. Limb sealing defect. Thalidomide is the main culprit drug, true. Thalidomide used for morning sickness in the female, for vomiting, and it causes thalidomide causing phocomelia, limb sealing defect. Defect in the development of long bones. Yes, these long bones are affected, not the flat bones, not the flat. So the correct answer is option D. This is option D. The defect in the flat bone is not correct. Phocomelia. So what is the drug we use for morning sickness nowadays? We use the doxylamine. Doxylamine with vitamin B6. Doxinate. So not this. So there is a bad history about thalidomide. 1965 में यूज हुआ. प्रेगनेंसी में लोगों ने यूज कर लिया. It was immunomodulator, immunosuppressant. खतरनाक. More than 10,000, 15,000 babies in Europe, abnormality. Next question. Hemolysis in G6PD deficiency. All are true except. So it is one of the pharmacogenetic condition where the genetic variation can lead to variation in the effect of a drug. There are some drugs which are causing hemolysis in G6PD deficient children, like anti-malarial and urinary antiseptic. Anti-malarial and urinary antiseptic. Anti-malarial and urinary antiseptic. So like Primaquine, anti-malarial. Like cotrimoxazole sulfa, urinary antiseptic. Nitro, antiseptic. UTI. The enzyme, yes, the enzyme is not galactose. The enzyme is glucose 6-phosphate dehydrogenase. Very good. सही पकड़ लिया. So enzyme is G6PD is glucose 6-phosphate dehydrogenase enzyme. So some drugs causing hemolysis in G6PD deficiency, that is glucose, not the galactose. बहुत बढ़िया. So what is correct in given dose response curve of a drug? What is true regarding the DRC? So we have the drug ABC. This is dose and this is response. So I told you, for efficacy and safety, HELP, height for efficacy, 50% response, left side drug is more potent. Left side means this one. The left side means the drug is less dose. Less dose means more potent. So height for efficacy, left side for more potency. So let's see, out of these for efficacy, A is equal to B, and then we have the C. C is least efficacious, height is less. But what about the potency? At 50%. So this is 50%. This is the 50% of this. So out of the maximum, we need to see the 50% response. So for 50% response of this, the dose. 50% the dose. 50% the dose. So you can see the drug is left. A, then B, then C. So this is for 50% the dose requirement. So B is the drug. B is. So you can comment in the answer. Yes, bache. So B is more potent than drug A. Is this true? You can see B is more potent than the drug A. That is false. A is having more efficacy than B. You can see they are having equal efficacy. A and B are full agonists. That's why they have the maximum 100% efficacy. You can see 100% maximum response. That is true. All are true? No. So that is option C. So you can see 100. That means they are full agonist. Efficacy means maximum response of a drug achieves irrespective of dose. You increase the dose and check the response. Whatever will be the maximum effect, that is called as efficacy, irrespective of a dose. So remember the mnemonic HELP. Okay. So by DRC you can check the, or you can compare the efficacy and potency. Which of the following is an example of physiological antagonism? Always remember, physiological means what? Physiological means the target or the mechanism is different, but the physiologically response is opposite. That's why they are used as antidote, physiological antidote. The mechanism is different, but the response is just opposite. There is no competition. Very good effect to treat the poisoning. Let's see one by one. Prostacyclin and thromboxane. Prostacyclin causing platelet anti-aggregation, thromboxane causing platelet aggregation. Heparin protamine. Heparin protamine. This is acid, this is base. Adrenaline phenoxybenzamin. Adrenaline is alpha agonist, phenoxybenzamin is alpha blocker. So alpha agonist, alpha blocker. These are receptor antagonist, not physiological. These are receptor antagonist, or you can say pharmacological antagonist. Receptor means pharmacological. So same receptor, alpha agonist, alpha blocker. So receptor or pharmacological antagonist. Heparin and protamine are acid or base. So this is chemical antagonism. Chemical. Prostacyclin and thromboxane using the different mechanism and having opposite action. Prostacyclin from endothelium, thromboxane from the platelets. Aggregation of platelet, anti-aggregatory of platelet. So different. So the option A, that is physiological antagonist. So two drugs produce opposite response via different physiology. Second last question. True regarding competitive enzyme inhibition. When there is competitive inhibition, they binds to same site as substrate. Yes, the same site. Then only there will be competition. Effect is surmountable. Surmountable means reversible. So when you increase the dose, the effect can be reversed. So that is also true. In competition, it is reversible. Raise the KM and no change in efficacy. So what happens in competitive enzyme inhibition or competitive receptor antagonism? Suppose this is the drug A given alone. When you give the antagonist, this antagonist, you can achieve the same response. So after adding the antagonist B, you achieve the same response. You can see the efficacy is still same, but to achieve the same response, we need to give the extra dose. We need to give the extra dose. If the dose requirement is increased, that means the potency has been decreased. So this Km is related to potency. Km is basically the dose. So the dose has been raised, yes. So Km is inversely proportional to potency. So Km is the dose for potency. So you can see, raise the Km, yes, the dose requirement has been increased. Graph has been shifted to right. But the height is same, so no change in efficacy. So that is also true. That is also true. Now you can see that it is same efficacy. You can achieve the same height in the competition, but you need the extra effort, extra hard work. So the dose has to be increased, the potency will be changed. In enzyme, we use the word Km, Michaelis Mental constant. To achieve the 50% of maximum effect, what is the concentration or dose required? That is called as Km. And the last is, which of the following drug a warning is written to be sold by retail on prescription of a registered medical practitioner only? Then which drug this warning will be written? H, X, Y or J? Y is already out, that is for clinical trial. Now we have the new drug and clinical trial rules. So this is for prescription drug. In X they are narcotics. This warning is also written on the X, but in X we have the two warning. One is this one warning is sir, the drug is not safe. The drug is not safe without advice from registered medical practitioner. Both warning will be written. So this is narcotic, but H is sold by retail on the prescription from the registered medical practitioner only. So these are the prescription drugs. The drugs which are not prescription drugs are called as over the counter, OTC drug. Over the counter or OTC, like paracetamol, antacid. They are the over the counter or OTC drug. But this is schedule H or H1 drug. So we have covered almost all the topics in general pharmacology. We tried to at least cover one MCQ from each topic. These are the links where you can find the more questions as well as important updates about the pharmacology. So you can follow me on these links, and that's all. So thank you guys, thank you, keep studying, keep rocking, take care, bye bye.